Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 178. It's a beautiful spring morning here in New York City, and to get you all started, we have a most interesting, challenging case, something which I'm sure you are confronting in your practice more and more often. It is accessing a LAD in this particular case via a recently placed actually Evolut supraannular TAVR device. There are going to be issues regarding accessing the vessel, and of course you'll learn important lessons how to do it, how to size it, the best approach, and of course dealing also further with the complex bifurcating LAD diagonal lesion. With this introduction, let me take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are already there. Samin, Anu, good morning.
Good morning. Good morning and welcome to our viewers. And every time we try to show some different, and next month actually we'll give the data of our monthly viewers. I know that last 2 months have been a terrific cases. One with the double vessel, double mini crush, and other one with the large calcific nodule with the step-bar rotatripsy. And this is another one which people are encountering quite a bit, is the patients coming for PCI, either planned or unstable with the post TAVR. So let's start this case presentation. We go show the slides. Good. These are our same supporters. Although now, as you know, let me see if I can take it back. Yeah, the shock wave, as you know, soon will become J&J also, just like Aviomed. Shockwave and Johnson Johnson has purchased for $13.1 billion. That was the big news last week. Disclosures are the same. This is the case number 178. Patient 70-year-old has a chronic coronary disease, CCD. You know, we used to call stable ischemic heart disease. Now this word of the CCD has become ACS or CCD. I mean, I thought it should have been a CCS, but they don't want to make that word. They're called chronic coronary disease rather than chronic coronary syndrome. It could have been a CCS, ACS. But the final language is now chronic coronary disease. For last 8 years, patient had known lesions before, and patient presented earlier this year with both progressive dyspnea, little bit of chest pressure, and had both CAD progression and aortic stenosis, and had a self-expanding valve TAVR on February 8. So good risk factors, as you see on the left side, good medical therapy, and good ejection fraction with mild pulmonary hypertension. So what happened is, after 30-day call, every patient comes back as a part of the TVT registry follow-up post-hour, 30-day and 1 year. We do all the blood tests, echocardiogram, in addition to physical exam. Patient was good at 30 days, feeling much better, but then 1 or 2 weeks later started having more shortness of breath, and we'll tell you why basically. And so initial improvement, first you think about valve pathology. The 30-day we do echo was perfect in this with a minimal gradient of single digit, no PVL, and therefore we felt now the coronary is causing the problem, and coronary, which will show, which has a 2-vessel disease with RCA total and significant lesion in the tortuous LAD diagonal system. So with that note, we are going to show this patient will be no diabetic, and patient has no stress test, and will fall into this category of intermediate risk. So Anu, you want to show what we have now?
I never did the angio.
Yeah, do it now. There's something. Let's engage it. And we actually did the angiogram that time, at the time of the TAVR. So what is happening nowadays is we are doing the angiogram at the time of the TAVR. Yeah.
So you see that this is same. I think if we have TAVR Cath, that's one app where we
Let them play that
published how to engage after TAVR valve, especially when you have the self-expanding valve. It's like a cage that sits there. So normal we go with the FL diagnostic would be FL40. So what happens once you place the TAVR valve, it's a rigid structure that's sitting there. We normally recommend use a smaller, so like a FL35. So this is the FL35. Patient had a totally occluded right coronary artery, so we did not go to engage that at this time. So this is a FL35. You see that you go with the J wire, and with the J wire you have to enter the valve cage. So you very careful, do not go with a J wire, enter the valve cage so that you know you are in the center of the valve. You see that? And you're hitting the valve leaflets. At that point you remove that, and here you are. You can use the J wire. This is a little bit of dye to say this is where the left main is. Now you have to see the diamond, so we will show you the 3D picture. Yeah. So can we show that animation that we have created?
They can show the animation also. This is 3.5 or 4? 3.
This is 3.5.
Yeah. So always half size lower.
Yeah.
And fit in nicely. That's
so you have you see that there's non-selective picture to understand exactly where the left main is coming off. Then you have to go clock counter, so you will find the right diamond. So
Anu, should these cases be done preferably femoral access?
it's difficult to say.
Yeah, that's a very good point. Yeah.
Now, so, can you show the animation?
Yeah, they're ready. So the question was, when we had the paper in JAC, we did have a letter to the editor. The people, we emphasized these cases should be preferably done by the femoral, but a lot of, I would say the radial gurus may do it by the radial, but preferably femoral, I would say, yes.
Because so this is the 3D animation, bird's eye view, exactly what I did. So once you are there, no, this is wrong. Engagement has to be shown. You're already showing intervention. Go back to the engagement. Do you have another engagement?
Samin, have you found any particular brand of the guiding catheter which is probably softest tip or helps you better?
With the Evolut valve, yeah.
So very good point. So what we do, actually we use majority of the guide catheters are the Mach 1, which is the Boston Scientific soft one. There's stiffer one, which is a runaway. And then we have the EBU catheters of Medtronic, and so I would say many times actually usually we don't use those stiffer guides, but they may be preferred in these cases because what happens is gives the support. But look at the calcium in that LED. Calcium.
This is okay. No, I don't know. This is mitral.
No, that's okay. But you have the nice calcium in the earlier view in the mid LED at 1 o'clock, not at the 12. 1. That by definition, tram track sign. Entire LED is very calcified, which is not uncommon in these patients with this age, when they already have a calcific aortic stenosis, mitral annular calcification, and the entire LED is clearly the ghost tram track. We are taking a picture now. You want to give a little nitro or no?
Go, engage.
Okay. Yeah. Look at that. Actually, nice engagement. Look at this. Very good engagement.
Nice engagement.
Yeah.
And that makes the case straightforward, really. It's fortunately the diagonal doesn't look to be involved, so
pull back.
The diagonal is there, but further down. Yeah,
right, further down.
Yeah.
But
and that's it. So clearly, it's a proximal LED, or kind of mid, because after the septal, very calcific. And we are the 6 French guide, and people do ask that can we use guide liner? Yes, you can use guide liner to put your rota bar, but require 7 French. Some cases orbital may go through the 6 French guide or guide liner, but otherwise you need to require the bigger guide catheter if you need to use these catheters, the atherectomy catheter, particularly the rotablation, even 1.25, 1.5 can go through the 7 French. So now here, the wire went in and has pushed the guide out a little bit.
Yes.
I was surprised.
No, it's a circle. There is a circle already.
Okay.
No. It's okay now.
Yeah. So this is the case. You will not do the direct wiring. Yeah, here. This is the fielder run through.
Fielder.
Okay. Yeah, look at this. Yeah.
After the diagonal, there looks to be a 30-40% lesion also, but doesn't. I think.
We would just focus that prox
Yeah,
LED there, right?
that's what I would say. In this particular patient, now only question comes is that some people may say, do you need to do a imaging, I mean physiological particularly, in this case to really say that that is causing the trouble. So, but I think since patient has this known disease, the diagonal patient has a diagonal disease in angiogram of 2016. That's the first time when it was left alone. No PCI was done back then.
So your task today became easier because with the rotablator, the patient already has the pacer there. So
Right.
one less step.
That's enough. That's enough. Good. Take the wire out. Yeah. Let's bring the rotor 1.5 bar or 1.75.
I would go 1.5.
1.5. Yeah, 1.5 is a good because if need to be do with the cutting balloon or followed by IVL. So combination of rotablation and I say that rarely you need to go to a bigger bar nowadays. Anytime you're thinking 1.5, 1.75, go to the smaller one. 1.5 because if you need to be, you can add on with the IVL. Okay, give us a 3O15 balloon. 3 or 3.5? 3O.
I think the goal in this case also should be, you see the prox LED just at the level of that small septal, just focus on that particular lesion and try to come out.
I mean, it's
with a good
amazing
result.
how far the guide backs out each time
Yes,
you
yes,
advance
yes.
the wire.
Yeah.
It's,
So
Yeah.
it's now try to keep.
Yeah.
We're going into a septal there. Yes.
right. It's
That's enough.
Okay.
We don't need further.
So once
then
once you don't have guide support, try not to go around doing handling all the complex lesion. So the symptoms likely from this prox LED, I know we are talking, so disease in other areas also.
And RCA is total.
Yeah.
But RCA is again known total since 2016. So we actually had this LED lesion is new when we found it in February of this year at the time of the tower placement. But the diagonal lesion of 60% was there, maybe 60, 70 then became. Then the RCA total was there at that time and patient has done well since then. So therefore, a new change was this lesion in the LED.
yes, surprising it became so much more significant in such a short time.
Yeah. No, sorry. I'm talking about the first angiogram was 2016.
Okay. All right.
LED was not there. No,
Okay,
but this lesion, we saw it in February 8th. LED lesion was there, but we said, let's do the medical therapy. Now, these are the patients are being enrolled at this time called complete tower trial, but has to be sapien valve.
Can we show the animation full screen?
Okay. While they're bringing the animation full screen, just to say, there is an ongoing trial, complete tower like this kind of case, not the left main, that should you even do a PCI? And that's being evaluated at this time with the complete tower trial, medical therapy versus PCI in those cases.
So if you see here exactly the way I showed you. So use the J wire and very important, you go in the valve with the J wire inside the valve. And then since it is a smaller catheter, usually it will curl up. And that's when you try to use a wire without the wire, get into the diamond and then advance. And when you're coming out is the same, use a J wire. We normally do not use but the J wire to come out so that you are taking the guide through the diamond carefully rather than just take it aggressively. Yes. You can see it once again. Yeah.
A question has come. This is Dr. Mohammed El Rais. I think he's from Egypt, if I remember it from before. He's asking, should you be using radial access? Would left radial be a better option?
Well, I mean, I would say that I cannot say answer for sure because we don't have experience on that. So any time when post-tower patients come, the most of the time we try to go by the femoral approach. But there was one patient which I did multiple, like at least 7-8 PCIs, all with the left radial. On that particular case, patient had a lima also. So that the patient, like for 5 years post with the 6-7 PCIs we did through the left radial. So rare cases we do radial, but I'm sure, I have no doubt that radial expert will say this is a straightforward case from our point of view, go from the left radial. So nothing wrong in that. Yeah. So our answer to that is you are very good at radial. This could be a good case for radial. Only question, remember in these cases, what I say, radial as such. 1 second. Yes.
What's going on here?
Okay. As such, the radial support crossover, every trial has shown between 5 to 7%. And here you'll need a more support. And then, particularly we are talking about the self-expanding valves. You'll require more support, and therefore radial will give you less. So we have 2 times, I remember, we did a right radial and not the left, right radial, could not get support, and we went to the femoral, which was difficult anyway, but we did it. No, we had to come out first.
No, guide is coming out.
No, I know, but this, you want to go with the dynaglide?
Yes.
Okay. All right. So anytime, just show that. So there is a difficulty with the guide, you just go on the dynaglide. Go. Advance.
The way the guiding catheter has been bobbing back and forth, is there a significant AI there?
No. That's the way it behaves.
Yeah.
Yes. Once you have this, so.
You saw that on the guide by pressing the dynaglide and brake release, that we advance the burr into the left main. So rather than push and pull, guide comes out, you just advance forward. So rather than coming out, you are going forward. Yeah. And we are ready now.
Get the run through wire ready.
Into a row, show the IVAS. It need to be. Yeah.
No.
Make it interesting.
No need.
Show the cut. Yeah. Wait. Yeah.
No need.
Make it interesting.
Nothing. Not to be
Now,
imaging
the
every single case.
creatinine is 2.7, and patient is anemic with a hemoglobin of about 8.1, right? Or 12.6 now. Sorry, 12.6. So that's good. No more longer anemia.
Okay, crossed
Got it.
right away
Crossed,
there.
yeah.
Exactly that pause which was needed. Anu,
I
very
think I'm going to
elegantly
come back.
done, as almost always. Yeah.
Yes. So this is where our
Don't
goal
go
was, and I
Right.
will just stop here.
Yeah.
Huh?
Yeah, don't go
Yes,
at the
yes.
angle. That
Done.
was the plan, was not go beyond the angle.
Yes.
Yeah. Now, to make it interesting, although the wire, the FFR, IFR wire will be very tough to go further, but it's nothing wrong after stenting. That then we do one thing we should do. Maybe the FFR to see that residual lesion of the mid LAD is not causing the trouble. Because in this case, if symptoms continue, always the right coronary is with the flush ostial occlusion for so many years. So that nothing to be touched. Whether mid LAD still continues to be symptomatic for somebody who has a normal ejection fraction, I would say no, but will be only way to document will be by doing the FFR. Or in the pre-TAVR, we do IFR, but post-TAVR, I think FFR is good enough. 1 second, we'll give in nitro. Good. Yeah. Okay, let's put a wire.
There is some background noise.
Yeah,
What
what is
is
the
it?
noise coming?
Well, let's
In
look
the
into
microphone.
it. We'll look into it.
Okay. Yeah. All right. So far so good. Which I say it has shaved a little bit of one side. You see the haziness has become less. And
Let me know if that is corrected now. The flow is very nice in the LAD, and
what do you need?
Samin, another question from Dr. L. Rice. Is there concern of impairing collateral flow to the RCA with rotablator?
So that is absolutely very good point. And those are the data have shown, particularly with the septals giving collateral that are after LED intervention with a totally occluded RCA, despite a good normal function, they become stunning of the inferior wall. And that, yes, the whole purpose there is that you do your rotational atherectomy correctly, and that should normalize after the procedure is done. But yes, sometimes it can give trouble and can last for some times. And this is where many people that, like you mentioned, that when RCA is total, you're working on the LED, in the rotablation, they put a pacemaker just for this because it can really cause that trouble. We have seen some cases like that. But yes, you had to be cognizant about it. But the whole thing, if you had not created the slow flow in the LED, then unlikely it will be affecting the collaterals of the RCA. But yeah, LED start having slow flow, then you definitely will have a trouble in the RCA also. So like this case here, there is a nice flow, no slow flow. But if you start having a slow flow in the LED, the collaterals will be badly affected.
So, Samin, we welcome. I don't remember ever having followers from Albania. So we have Dr. Edison Katana, who's written a very lovely note. Greetings from Albania. Your cases are very didactic and inspiring. Edison, thank you so much. And welcome to our webcast. Spread the word around. Excellent source of completely never conflicted, just doing academically the right things for the patient, and happy to have you over.
So just to say, I think Mohammed had the question, left radial. Look at this, after even rota is giving a trouble, although we went in. See the guide? So interplay of the guide, and so we know with the radial will be more troublesome. But if this has finally made it, we can do it.
No, it did not. It did not cross the lesion. Some die.
Yeah, bring the guide in. Yeah, good.
The guide is not going either.
Good. No, we'll be okay. Otherwise, you'll bring a short balloon. You'll be okay.
No.
Yeah.
I think no.
If we let's do here, otherwise 3O cutting balloon will be good enough.
First, you have to go with, I think, a compliant. Okay, go up here.
Yeah. No, I'm saying even this one, what is happening is it's just the tail. Yeah, now it will go.
Okay, down. Wait. Let me see if I can engage the guide better.
Yeah. So when your balloon is inflated, then you advance your guide. Let's do it now again further.
It's getting stuck in the...
It's going to go. That's it. At the level of the diagonal now. Yeah. Okay, now what stent you want to use?
I mean, for various reasons, if one is doing a circumflex through self-expanding TAVR or the right coronary artery, the amplats should probably be avoided, no?
Yeah, exactly. Yes.
The amplats, I don't think we'll be able to engage.
Engagement will be tough also.
Okay.
Good.
Down. So I think we take a 12 stent.
Yeah, 3.5, 12. Synergy or science? What do you want?
So you were mentioning towards the beginning of the case about possible IVL here. Absolutely.
Yes.
No reason you're happy with the result with the rotational ablation.
No. Well, I mean, rota sure, but we knew that rota IVL would not have gone. So after the rota, the question was do balloon dilatation, and if you cannot open it, there's no need for extra burr. But then you do that in that particular case you combine with the IVL. So that was the key.
Oh.
Yeah. You want
like
longer.
Stent-like result.
Yeah.
No. Why?
No, 12. I think we have ablated little that area. I think you use a
16.
Yeah, 16 or 20. 16.
No,
16.
Not
Synergy 16.
You see the guide barely in the sinus.
Yeah.
Right.
But now it's okay because once you have done the rota, now you can bring your guideliner or Godzilla and then do the case. But the whole case was trouble. The initially could be the issue. But now we are putting a 3.5, 16.
Not 3.5, 3.0.
3.0? Why 3.5? Balloon was what size?
3.0.
3.0.
We put 3.0 if you want, then we can post it.
3.25.
Yeah, exactly.
But I only think the synergy is not in 3.25.
No, 3.25 post, he's saying.
Yeah. and post. Yeah, 3.0 and we'll dilate with a 3.5 actually even, or 3.25, whatever you want. Yeah, give
Distally
this
is
one.
not that big.
Okay.
SS.
Then give us a 3.25, 8 or 12 balloon.
Yeah.
Yeah. This one, even synergy with the thin struts may still have a trouble going in because of the calcium in the proximal. So there's no disease proximally, angiographic, I mean, but calcified. So this may have a trouble delivering the device. And that's what we say. Calcium is not only at the lesion, not letting your lesion to expand, but also delivery of the devices may be hampered.
So the question probably, if I'm reading it here, is about your cocktail which you're giving. I mean, the question is, or are you giving something prophylactic to guard against no reflow?
No, but just what in the verapamil, nitro, heparin. Yeah, good.
Pull back a little bit,
Yeah.
no?
And then the rotaglide. And now we have removed the rota wire. You saw that?
Yeah.
Yeah. Okay.
Yes. Okay, go up.
It's a synergy. You could go 1 millimeter in.
No, it's okay.
Go.
Good.
Trying to stay away from that
Yeah,
distal
that's
tortuosity.
yeah. Because you start getting a diagonal, and particularly diagonal in 7 years or 8 years actually has changed just by 10-20%. It was, we have the old angiogram was 50-60%, now maybe 70%.
You have a, you want, what did you say, 3.5 proximally? I don't know.
Yeah, no, we're getting a
To me looks
3.25
good.
balloon.
Okay, take us in now.
Yeah.
Ready? Good.
Yeah, just
Looks
that
beautiful.
area need to do a little.
12?
Yeah, 12. We had 3.25, 12. Okay, you want to show anything with in addition, take this wire out.
No, do we have the one where we use a guide liner and we do the PCI? I mean, we've shown how to do PCI. The animation with using the guide liner, Andrew? Now we go back to the PCI animation where we have the bird's eye view.
Good.
Okay, go up. 16, 18.
20, no?
Okay, down. I'll go a little bit inside
Yeah.
and that's it. Done.
Yeah.
Go here. 12. Okay, no more. Don't go. Okay. Down. Okay, animation is ready. Okay, let's go full screen.
And the commissural alignment is very important for engaging the particularly in the self-expanding valves. The commissural alignment actually has become important factor in the TAVR durability, even when the balloon expandable, but more so the self-expanding, because if your commissure is in front of the valve, in front of the origin of the vessel, you cannot engage. We have patients where could not be engaged after putting the our Evolut valve. And rarely patient went for surgery or nothing could be done in 1 or 2 patients. So that always is a troublesome.
So here the way we have, so we are showing it, you see there, we are counter clock to enter into the diamond. We already have the wire there sitting in the, so we are wiring with the guide just at the, ostium or the face of the diamond. And you're all the way down and you have the balloon. And once you anchor, you can get your Godzilla or a guide liner into the vessel. So that's how we are showing it. Yeah.
Dr. Nikhil Jha had actually inquired about guide extension catheter. So Nikhil, there you have a wonderful demonstration. But Samin, he's asked a very interesting question. How do you confirm if the Evolut got deformed or not?
No, it's very clear on the cine now.
Yeah.
You can show it.
Yeah. So,
There's no way that it can get deformed. It is look at the diamonds, the way diamonds have been created. Yes.
yeah, there are four.
I'm just
Yeah.
wondering if his question relates to some role of imaging there.
No. How will imaging show that the diamonds have been distorted?
By withdrawing on the guiding catheter all the way?
Yeah.
No.
Yeah. No, but the question
what you're
is,
saying is not needed. Yeah.
Not needed, you will not be able to see it.
yeah.
Right.
No, the question is also maybe the distortion is, is not reported. What has been reported that you have now, you have guide liner or your wire is in the main vessel. You have put a Evolut valve, and that wire is keeping the ostium of the side, your left main, let's say, or RCA open. Now you take the wire out, all of a sudden collapse and cause the cardiovascular collapse. So that actually has been shown that in that case, then you can do the imaging IVUS particularly and see if there is a flap or there is a obstruction of the ostium of the left main. Then you need to put a stent, because key is you have to take a picture when you are doing a left main protection particularly, or maybe as I said RC also, that you are taking a picture without the wire, because otherwise the patient may have a closure of the coronary vessels 1 or 2 hours later, and that could be very catastrophic. But yes, by the deformation, no, yeah.
Have you encountered any cardiovascular collapse in any of these cases?
Yes, it happened. Yes, that is correct. The occlusion of one on the table happens, overall incidence of coronary occlusion about 0.6%. On the table actually is more with the SAPIEN valve compared to Evolut. Outside, once you come out of it, later on, obstruction of the coronary is much higher with the Evolut compared to SAPIEN, because SAPIEN frames remain below the coronary ostia, right or left. Now,
so
acutely...
Let's go back to what Dr. Sharma right now mentioning is what is in the literature. What we have seen in practice in our hands is with the self-expanding valve.
So, Samin, here the next, I think, a straightforward follow-up to what you just mentioned is, so is there anything different you do for discharge management of these patients, keep them overnight?
Well, but most of them, just because of the age, they're usually in octogenarians, and so just keep them overnight. Sometimes it's the simple case. After atherectomy, they should be overnight anyway, because that's inpatient DRG. But other simple case, you do just the IVL, that patients can be discharged, but have to be a little extra careful, make sure there is a full follow-up. And you look at this, it's fantastic there. So I think the main purpose of the LED has been done. So I don't think we need to worry about doing the FFR. FFR may still be positive a little bit downstream. And we all know that almost 22% of cases with a successful angiographic area of the opening, that you still could have 22-25% abnormal FFR. And trials have shown that whether you should increase, go back, dilate, or focal, put another stent, and so is all questionable. So I think angiography looks good. It's okay to avoid just putting the FFR wire here, because very tortuous, may even create little trouble. May not go further.
Exactly the questions regarding the FFR asked by Dr. L. Rice.
Yeah, that's absolutely correct. And although there are trials ongoing at present, FFR guided intervention in post-TAVR patients, but the guidelines at present is very simple. You have a 70%, more than 70% obstructive disease of the epicardial vessel. You just go and stent it in those cases. That's a guideline. Because you know that you cannot do FFR, IFR, more troublesome. Then they cannot have a stress test. So it's just by the angiographic guidance. Good. So anything else you need to point? Now you take the catheter out. You wanted to take it out with the wire or with the guide wire or just this wire?
No, I just
show
took
them
it out of
fluoro. Yeah. So you wanted to show that you need to.
No, they are right there.
Yeah.
So it can popped in again.
Right.
For a different diamond. Counter it out a little bit and then come out.
Yeah, there are in the literature the catheter, particularly the freshly placed the TAVR valve in last 3 to 6 months. That during the guide it has been embolized. The guide pull it out and lead to the catastrophic complication. So just have to be careful. Step by step. If something is coming out very easy, then it's okay. Yeah,
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 yeah, no, I'm going to
yeah.
clean.
Okay, with that note, let's come to our presentation now, uh, which is very nice demonstration. We thought it will be very, very complex, but went by step from the help of Cath. We can go slide presentation, and now this will be what I'm going to talk today is the 4 trials. There are a lot of good trials came out in ACC. A danger shock, but I'm going to talk about the 4 of them. Danger shock, ultimate DAPT, TAC2, and Orbita Cosmic. And then focus review of the month will be prophylactic PCI for vulnerable plaque, which we have been waiting for long time. And finally, we have the data on the preventive PCI versus optimal medical therapy alone for the treatment of vulnerable atherosclerotic coronary plaque, which is the PREVENT trial. So let's just start with our first trials of intervention in the danger shock. Now, as you remember, that we have an ECMO trial, Expella and ECMO shock. 2 trials last year. In cardiogenic shock, both were negative. So this is the first trial now, which is positive in the cardiogenic shock. It's the microaxial flow pump. They call it in abbreviation MFP. That's basically Impella. Versus standard care in infarct-related cardiogenic shock. And this was done, started with the Denmark. It used to be called danger shock. I mean, Dan shock trial. But then there was a poor enrollment. Then they went to Germany and other places. Though the name became danger shock later on. So basically was that patient with the conventional arm group versus control arm group, that patient received the Impella, and there the whole system of the escalation, when to go, and so on and so forth. And basically what it showed of the 360 patients, intention to treat standard care versus intention to treat microaxial flow pump, which is Impella. Majority was CP. There were some cases also was the LP, and then these patients were followed up to 180 days. The endpoint was death or major adverse endpoint at 180 days, 6 months. Now you see here, this is the trial. First time a trial has shown 13% absolute reduction in mortality at 180. So key is that still about to be learned, the cardiogenic shock mortality at 30 days still remain about 50%. Therefore, it was able to reduce it from at 30 days, as you can see here, from 50% went down to about 32%. But the primary endpoint was death at 6 months, which was 58.5 versus 45.3, and other endpoints. Composite endpoints on the right side, in addition to just the death, was clearly also decreased in the microaxial flow pump plus the standard care. So this basically is 30% absolute risk reduction. Number needed to treat 8 patients to save 1 life. Very, very remarkable. Just want to emphasize, having a 13% absolute reduction, the TAVR became successful because it saved 20% mortality, lower mortality in the TAVR group compared to conventional when they did the original trial. And therefore, it's basically is a very remarkable positive result, first time of the mechanical circulatory support in patient with a cardiogenic shock. Now, individual groups, actually they showed the sicker the patient, the male, and lower the blood pressure, it has a better outcome. Then, of course, the escalation. The patient with the cardiogenic shock escalate to the more higher, which is the ECMO or permanent LVAD, and so you've clearly seen that the escalation did occur in the bottom, 15.6% in the Impella group and 21% in the standard care group. It was avoided in the standard care to put Impella. But more important is the ECMO and others were done, and these are the individual, as far as the PCI, they're all equal. Door to balloon time, culprit, non-culprit PCIs, and so. But you can see clearly that only 2% in the standard care group got the Impella, but VA ECMO and Impella 5.0 was much higher. in the standard care group. So yes, in the standard care, they allow the Impella 5.4, which is the surgical cut down. So overall, you can see 19 plus 45, 64%. The escalation required in the standard care compared to 16% required in the ECMO group. Very important, I mean, in the Impella group. And these are the days out of hospital. Basically, overall, it improved the life of the patient by days alive. So these are the individual endpoints as shown here. So while the first line looks great, which is the death at 180 days, but it comes with some price. And what is the price? As you can see here, that safety endpoint. So safety was compromised, which we understand because of the large bore size and the higher bleeding, higher limb ischemia, sepsis, and renal replacement therapy. Remember, there was a concept that likely the Impella improve the renal function. Answer to this in this trial was no. Renal replacement therapy was 42% in the Impella group, 26.7% standard group. So renal protection in a randomized trial have shown no benefit of Impella. So this is something we also learn now. Therefore, the conclusion was the routine use of microaxillary flow pump with the standard care in the treatment of patients with STEMI-related cardiogenic shock led to a lower risk of death from any cause at 180 days than standard care alone. The incidence of a composite of adverse event was higher with the use of microaxial flow pump. So what does it mean? That while we understood this, but now next level is why this happened? Because of the vascular bleeding. So because of the 14 French sheath size. What if we bring it to the 9 French and you'll have a lower vascular bleeding and lower vascular complications? So this is what we are, next step, as you know, many devices are coming into that line. ECP or the Impella group, they have their 9.5 French. Then we have Magenta Medical, 9.5 French. There is another one, or Supira, 9.5 French. So those will change this landscape of mechanical circulatory support devices in our lives, that they are good and associated with good outcome, yes, but at the same time, hopefully will not increase the bleeding and vascular complication. Yeah. Yeah. Yeah.
In PROTECT trial, okay, they are very clear with the access management. Access management means that ultrasound guided, very close, and if you not normally use the
Close.
then you have to have an access on the other side to do up and over. You could hear me, right?
No, Anu, not in the last. I was wondering.
Okay. No, my comment was with regards to the vascular closure. In PROTECT trial, there are very clear guidelines how to do the vascular closure when you are using, when they're randomized to Impella, means ultrasound guided access with pre-close. And if you're not able to get the pre-close, you will have to have an access from the other side to do maybe up and over and closure with the balloon. So we are not sure if that kind of a strict criteria was used here. If those kind of strict criteria are used, then maybe the vascular closure means we are saying that large bore access is becoming very important, and probably you need a dedicated team and teaching how to manage this large bore access when you are using Impella and any kind of MCS devices.
Excellent. Samin, there are many questions, but I'll wait for you to finish the presentation.
Okay. So yeah. So then,
no.
Let's go back. Yeah. So very, very important point. So vascular complication. Think about many of those patients in the Impella group, if they died, that may have been related to vascular complication. So therefore, if that number goes down, I'm sure the mortality difference will be even bigger. Okay, let's go to the second trial and we'll take all the questions.
You think a smaller device would also impact the renal complications?
That I do not know. So I think this came as a side kick of the trials, that some cases the Impella decrease the renal serum creatinine and decrease the AKI. So I'm not fully convinced of that, because those are from the retrospective data. We looked into our data. when we published the Impala versus no Impala and severe LV dysfunction, we did not find any difference in the creatinine. So I think this is some studies have shown, but this is first of the randomized trial which has shown no difference, and many of them are still coming, and then we'll know. So coming back to the point that what Anu mentioned, that vascular complication is so important. In these patients, the key is, like right now we have 60 patients enrolled in our Protect 4 trial, and we have 0 vascular complication. So require extra effort, extra I would say maintenance of the vascular access by the procedural planning, and then where to puncture, what to puncture, and so, and then up and over, and then post, whether use a 2 pre-close, 1 pre-close with 1 angio-seal, but that's a very, very important. So then let's go to the second trial, which is the ultimate DAPT. Ultimate DAPT was ticagrelor alone versus ticagrelor plus aspirin for 1 month versus 12 months for PCI. This is called ultimate DAPT. This was done in China, although some cases in Pakistan, Italy, and UK. So remember, the Twilight was 3 months. So it was same copy of the Twilight trial where we give 3 months of aspirin, and here they gave it for 1 month. And this is the basically, and then they actually had double randomization. Imaging guided versus angiography guided. So the about 3,500 patients randomized to IVUS guided PCI versus angiography guided PCI, and then they were further randomized after 1 month of ticagrelor therapy, of aspirin therapy and ticagrelor together both, that there was no event. Then they were randomized that stop the aspirin or continue aspirin for 1 year. So basically same. That just if you think about those, we remember our Twilight basically was 3 months, same thing moved to 1 month. And very interesting, these are the endpoint of the bleeding, and you can see here significantly lower bleeding without any effect on the MACE or Mackie. But more important, look at the graphs. I can tell you, you open the New England Journal article paper, it's exactly the same event rate we had. The bleeding 4.8 went down to 2.3. Or 2.1, and the ischemic endpoints were identical. So basically what it means is that you don't need to give 3 months of aspirin, 1 month is good enough. Can you even take away 1 month? I think there is some question about. There are some trials have shown that maybe give it at least for 2 weeks, but 0 is still being questioned. But I would say safely, antiplatelet aspirin can be withheld after 1 month, and this has been shown by other trials also, even with on the face of the clopidogrel. These are the individual endpoints. So basically was that patients with acute coronary syndrome who had PCI with contemporary drug-eluting stents and remained event-free at 1 month or on dual antiplatelet therapy, treatment with ticagrelor alone between 1 month and 12 months after the intervention resulted in a lower rate of clinically relevant bleeding and a similar rate of Mackie compared with ticagrelor alone plus aspirin. Along with the results from the previous studies, these findings show that most patients in this population can benefit from superior clinical outcomes with aspirin discontinuation and maintenance on ticagrelor monotherapy after 1 month of the DAPT. Now, you know the guidelines have changed both USA and Europe, having ticagrelor and 3 months of aspirin. They are not changed it to 1 month, but I think this will be a big impetus to change it to a 1 month of aspirin. Then there is a trial called TAC2. Those who remember the chelation, EDTA, sodium-based, because with cardiovascular events occurs after a patient with a CAD, that all these, the heavy and lead, all are associated with higher atherosclerosis. Now actually latest paper came that in the atherosclerotic tissue, they have found the plastics. You know, the plastic coming from the bottle. So they actually in the atherosclerosis, they have found the plastic fragments now. So this is going beyond. So idea is, what if you, by the chelation, if you remove these heavy metal, would you make the patients feel better? There was a trial done called TACT, in which about 1,700 patients, and they give a EDTA infusion. It's usually given once a week for 20 weeks. And they found basically is that overall EDTA was better as in the top, but major benefit occurred in the diabetic and anti-MI. So it looks like if you have no diabetes, no MI, was no benefit. But diabetic and anti-MI, so that TACT2 trial took this to the forward, that what about TACT in that giving EDTA in patients, post-MI patients with diabetes. And so they wanted to also see the mechanism. Do you really decrease the lead levels and cadmium levels, and so this is active infusion and placebo infusion, which was given with the 500 ml to both the groups. And you see here exactly identical outcomes of the MACE, MI, stroke, or death, no difference. So basically what it turns out to be that while we are able to decrease the EDTA, decrease the level of in the blood or urine of the lead level or cadmium, but there was no difference in the outcome. So basically you remove the metal, and now you say, well, how this effective was, because the reason is that at present our regular water has less metal. Maybe that the authors hypothesized that now there is a less metal in our water, and maybe that's why the benefit was not there. So this is questionable. So then another trial, the fourth trial, was using the COSIRA, called Orbiter Cosmic Trial. Orbiter because of the group of, the people who have made their name with Orbiter 1, Orbiter 2, the coronary sinus reducer for treatment of refractory angina. Placebo-controlled trial, and this is just to recapitulate. What is a coronary sinus reducer? That you through the vein, you put into the coronary sinus, and you backflow like retroperfusion of the endothelium of the endocardial blood flow. So vessel size created controlled narrowing 3 millimeter to modulate flow and elevated coronary sinus pressure. Coronary sinus pressure elevation increased endocardial perfusion, providing relief of ischemia and angina. So the hypothesis is that by putting the coronary sinus, you increase the myocardial blood flow of the endocardium. And this is where they wanted to do this trial of the Orbiter Cosmic to see two things. One, is there truly the benefit of angina? Second, why there is a benefit of angina? And this basically was a small trial, about 50 patients. And you can see here, the first one is the left. That was they saw the myocardial blood flow in the ischemic as well as infarcted segment. And that looks like stress MBF, multiple overlaps, no difference in myocardial blood flow. So therefore, the COSIRA did not change the myocardial blood flow in the ischemic segment. They also showed the data in the infarcted segment. No. What did show on the right side that the daily angina episode reported via the Orbiter smartphone symptoms, same thing which they did for Orbiter 2, the patients reported their symptoms, as you can see there on the coronary sinus on the left side, placebo on the right side, the darkness of the red, much more dark on the right side, so more angina episode in the placebo group compared to CSR. So yes, while individual endpoint of the CMR in terms of blood flow, other secondary imaging outcomes were not different, but definitely what was different is the anginal episode, which started after 2 days, got better at 70 at 6 months, significant reduction in angina episode in the CSR patients compared to placebo. So angina episode decreased, but there is no clear mechanism why it happened. It definitely is not because of the redistribution of the blood flow as been shown by CMR in this study. The complications on the right side shown, there is basically no complication, very safe device. We are a part of the COSIRA 2, at present ongoing in America for patients with the anterior wall ischemia in refractory symptoms like these patients, randomizing into the COSIRA versus placebo. And of course, this is a very intense trial. The patient cannot know what they received and so on and so forth. So basically, Orbiter Cosmic found no evidence that the CSR improved transmural myocardial perfusion, but the CSR did improve angina compared with placebo. These findings provide evidence for the use of CSR as a further anti-anginal option for patients with stable coronary artery disease. So question still comes, what is the reason for their benefit? So I think we cannot say for sure what the benefit is, but maybe it's not the placebo because there were the placebo randomized trial, but somehow it does decrease angina episode, and so that has been the trials other of the CSR. Now let's go to the most important trial, I would say, of the ACC, and that is the PREVENT trial. And PREVENT was the open label trial from Korea, of majority patients from South Korea, some in Japan, Taiwan, and New Zealand. And basically the concept was that if you have a vulnerable plaque, and how do you define the vulnerable plaque? What is the vulnerable plaque? The definition says MLA less than 4 millimeter square, plaque burden more than 70%, TICFA by OCT or radio frequency IVUS or lipid rich plaque on NIRS. So all these things can
identify the vulnerable plaque. There is a clear-cut definitions for them, and therefore the concept has been that which originated from the combined OCT FFR trial. So what they did is the patients, diabetic patients who are FFR negative or positive, means more than 0.8 or less than 0.8. Those who are less than 0.8, basically they got the stent. Those who are more than 0.8 and on the OCT, if they have a vulnerable plaque, they were followed. So one, the right lower, that if you have vulnerable plaque, your event rate was 5 times higher compared to no vulnerable plaque. So clearly, vulnerable plaque create trouble. Now what they did is that what if we put a stent in the FFR of more than less than 0.8, and we follow them with the patients who have the vulnerable plaque, which is on the right top, the 20% event rate, 25% event rate in the vulnerable plaque group who did not have any stent, and the patients who have a FFR of less than 0.8, event rate was 12%. So this is the data we have of a five-year follow-up. Now, the question comes that can you do this in the native vessel? So this is in a blinded fashion, and this was the trial, PREVENT trial, as I mentioned, that from majority South Korea, 1,500 patients, and they first identified that any significant epicardial coronary stenosis more than 50%, but FFR is more than 0.8. So they took the patient of the left side of that OCT FFR trial, the left side where FFR was more than 0.8, but those who have two of the following criteria of the vulnerable plaque: MLA less than 4, plaque burden more than 70%, lipid-rich plaque of the nears with 315, and TICFA defined by OCT or virtual histology IVUS. So there is a whole criteria that how do you define the TICFA in the virtual histology. They call it more than 10% confluent necrotic core with 30% abutting to the lumen in 3 consecutive slices. So after they had one FFR negative, second, 2 of these factors of the vulnerable plaques are present, randomized 800 patients to, initially they thought the concept of the BVS was a great one. The trial started with the BVS, but BVS was taken out of the market, so then they replaced it to the Zymes. But whole concept was BVS could have been the ideal device, ideal stent for these cases, or scaffold, but it was no longer part of it, and I'll show you the data of that. And then compared to medical therapy, optimal medical therapy. And optimal medical therapy, these are the individual imaging screening. You can see there, the OCT actually was used, and patient numbers, many of them have a multiple testings to make it to those criteria, and really showed that FFR was more than 0.8. Then IVUS, NEARS, OCT measurement, number of patients you can see, OCT were very small. The majority done with the IVUS measurements. And there some people say that's a plus and minus part of the study. And then number of the high risk features as shown in the bottom, that the 1 versus more than 1 present in many of these cases. Also very aggressive. Now you can say, well, a lot of people say, oh, there was no PCSK9, LDL was still about 70, was not 55. Whatever it is, this trial was done for 8 years. So question was, the lipid lowering the agents were used in large number of patients along with the secondary prevention with the beta blocker, ACE inhibitor, good control of the diabetes. In these patients, aggressive statin therapy was done in about 70%. They defined high intensity and moderate intensity statins. And risk factor control, the LDL, body mass index, specific blood pressure, diastolic, A1C, all as much as could be done, they did best in the trial. So now what happened is very interesting, that at 2 years, event rate with the preventive sealing, stent sealing, was event rate of the composite endpoint, which is defined as death, target vessel MI, or ischemia-driven target vessel hospitalization or unstable angina requiring hospitalization, occurred in 0.4% of cases compared to 3.4% in the placebo group. Significant 3% reduction, highly significant, and you can see they followed the patient up to 7 years. Part of the 7-year follow-up was because the poor enrollment, or slow enrollment, I should say. So the trial was supposed to be 2 years, but went up to 7 years because of the enrollment process. So many of the cases, not all, had a 7-year follow-up, and that was presented in this paper. And then on the right side is other patient-oriented composite endpoint, which are clearly shown to be important and different in 2 groups. Lower in the stenting group, compared to optimal medical therapy group. You say, well, why this trial became positive? Look at our complication rate. Stents are so good in these moderately or intermediate lesions that we have complication rate of less than 1% in 2 years. And then curves continue to separate, as you can see there. Why the curves should separate in the stent group? Because stent also will develop some restenosis, some target vessel revascularization, and so. Now this is a BVS versus cobalt chromium, our Zions. Look at this one. The BVS actually, I would say, muddied the data because event rate was 5.7, optimal medical therapy was 9.9, and cobalt chromium was 1.3. So very, very important difference. And just this shows, look at the number of people who are followed up to 3 year, 4 year, 5, 6 years. That by 7 year, we have only handful of patients, less than 10% made it to the 7-year follow-up. These are the individual endpoint. Primary endpoint, the death, MI, any revascularization, unstable angina. There's no difference in the stent thrombosis or the bleeding. So you say, well, we understand that. But is it related to the lesion? So I made this special slide for the target vessel MI and ischemia-driven PR, target vessel revascularization. And look at this one, that numerically, target vessel MI decrease was lower in the preventive PCI group and significantly lower ischemia-driven target vessel revascularization. Those likely are the responsible mechanism for benefit of the prevent trial at follow-up. So other non-cardiac causes and so which I'm showing here basically were not different. Angina actually was not different because these patients have moderate lesion. Many of them didn't have symptoms to begin with, but yes, by the end, because of good medical therapy, almost everybody was angina free at follow-up. You can see at 2-year follow-up, 85% of patients have almost less than or no angina. Then these are other the points in terms of interventional points which are okay, very low complication that led to the event rate of less than 1% in these patients. So what was the conclusion? That in patients with non-flow limiting vulnerable coronary plaques, preventive PCI reduced major adverse cardiac events arising from high-risk vulnerable plaques compared with optimal medical therapy alone. Given that PREVENT is the first large trial to show the potential effect of the focal treatment for vulnerable plaque, these findings support consideration to expand indications for PCI to include non-flow limiting high-risk vulnerable plaque. So answer that is, I would say the last sentence of this conclusion, I say, hold on. If we start doing it, you can imagine how much inadvertent PCI will be done because we'll be imaging every vessel and of course we can find some vulnerable plaque. So I would say there are 3 trials are ongoing at present and we need to wait for it. One is the combined intervene, patient with a chronic coronary syndrome, combined OCT FFR versus FFR guided PCI. Plaque, same. The vulnerable plaque cases and endpoint is MACE as composite of death, MI and the clinically driven revascularization at 24 months. Second, is interschema, that is acute coronary syndrome, 1400 patient, OCT guidance, and OCT, then you have the clear-cut criteria that which patient is the vulnerable, those patients get no FFR here. Those patients get the PCI. I'm sorry, what?
No, lipid arc is more than 180.
Yeah,
in
so
your PREVENT was
different.
90.
Yeah, no, because look at the plaque thickness, they're calling 75. Everyone has their own criteria. We have to follow that. The MLA is no longer 4, 3.5. Lipid arc 180 and presence of macrophage. They counted that 3 of the 4 has to be present, or sorry, 2 of the 3 have to be present, and they call the fibrous cap thickness of 75 micron, not 65 usually. But then an IFR FFR guidance, you do a regular PCI which has been shown on the right side, and then they say optimize the result to bring the post-stenting FFR to more than 0.9. Now, what is the primary endpoint? Cardiac death and spontaneous target vessel MI. No revascularization at 2 years. To me, if this trials become positive, this is the real one. That you are talking about the death and spontaneous MI at 2 years by combining or differentiating your lesion based on the OCT and IFR, FFR. OCT guided, they're saying unless it's a, more than 90% is not done. But other cases, you just go with the PCI, but based on the OCT, you do the PCI. The third trial is called Favor 5 AMI trial, 1,000 patient with a multi-vessel disease in acute STEMI, and there we have the new measurement of the FR called QFR, which we have shown, and then they have the regional wall motion stress. So they say RWS is a marker of vulnerable plaque. So they have the whole criteria. RVS has to be more than 13% and QFR less than 0.8. Do PCI, but if they less than 13% means it's not a vulnerable plaque, you don't do the PCI. And other side, you do a PCI based on your regular plan, that FFR of less than 0.8. If your lesion is 50 to 70, and if lesion is or 0.89, if the lesion is more than 70, you go ahead in the PCI. The incidence of MACE is very interesting. Here is the event-driven trial. They will wait for 395 events, and then they stop the enrollment or unblinded, and they think it will take 1.5 years. So these are the three major trials, I would say, answer this question of vulnerable plaque in the coming years. So let me just completely finish this one. The Impella use, what are the take-home message? Impella use in cardiogenic shock due to STEMI, I would say 3 thumbs up. Aspirin for 1 month over 12 months with ticagrelor in acute coronary syndrome, 2 thumbs up. IV EDTA plus multivitamin infusion in diabetic post-MI patient, thumbs down, no benefit. CSR stent in refractory angina for perfusion and angina, it benefited angina, no perfusion, so the 1 thumbs down, 1 thumbs up. But more important is the interpretation, which is a little long, but I had to read it. First randomized trial of the preventive stenting, which is the prevent trial for vulnerable plaque, showed significant reduction in the major adverse cardiac endpoint at 2 years, which persisted up to 7 years of follow-up. Main mechanism of lower cardiac events in the preventive PCI group was significantly lower TVR and slightly lower target vessel MI. So it seems to be it was a vulnerable plaque-mediated event reduction which led to this benefit. The positive results of the prevent trial establishes for the first time the concept of plaque sealing by stenting in these high-risk patients despite aggressive CAD risk factor modification, which was done as much as possible. You can add your inclisiran or PCSK is a different. The 3 additional trials are ongoing in the field of vulnerable plaque in various clinical settings. In the coronary, the chronic coronary disease, acute coronary syndrome, and post-MI patients, which will further corroborate the current results. If positive, then this thought-provoking, exciting concept will be incorporated in the guidelines. So therefore, wait till we start using this as a tool for the PCI. Let me go through 3 questions quickly. Following statement is false regarding the results of the danger shock trial. Lower mortality in the Impella group, higher bleeding in the Impella group, lower renal replacement therapy in Impella group, a higher vascular complication in Impella group, similar CVA in Impella group. So all are true except C. There was not a lower renal replacement therapy. It was higher renal replacement therapy in the Impella group. Second, following statements are correct regarding the results of Orbita Cosmic trial evaluating CSR stent versus placebo in refractory angina, except there is no difference in the myocardial blood flow. There is no difference in epicardial to endocardial ratio of stress myocardial blood flow in 2 groups. There is no difference in various imaging parameters in 2 groups. Similar MACE and complication between 2 groups. Similar angina episodes between 2 groups. Answer is wrong. E is wrong because not similar angina. Angina was significantly lower in the CSR group compared to the placebo. Then last one, following statement is false regarding the results of the prevent trial comparing stent plus optimal medical therapy versus optimal medical therapy alone in the treatment of vulnerable plaque. There is significantly lower MACE in the stent group. There is significantly lower TVR in the stent group. There is numerically lower target vessel MI in the stent group. Benefit of stenting was lost or diminished after 2 years. There was no significant increase in bleeding or stroke in the stent group. Clearly, answer is wrong is your D. Benefit of stenting was not lost after 2 years. It continues to separate till 7 years. And with that note, I'll stop my presentation.
I mean, amazing presentation to cover so much area, including discussing. It's almost like passing an editorial on the prevent trial, which is what several people had asked. Anu, you're showing something?
No, there was a question
Right.
would the diamonds be distorted, disrupted? I just want to have people an idea what the TAVR valve looks like.
Unless the guide
So,
there.
not that. First of all, the way when we are placing the TAVR valve, we definitely do what's called as commissural alignment. There are 3 posts here. You see there where the valve is attached. So, if your left main is in front of this post.
Anu, hold on one second. We are not. Okay, better now. Go ahead.
Okay, you can see better.
Yes, much better.
Okay,
Thank you.
So there are 3 posts where the valve is attached. So when we are placing the valve, we are very careful what we make sure is commissural alignment in a way that this commissural, so if you think left main is coming out this way, it has to be such a way the diamond, the post is not in front of the left main. So the diamonds that are in front of the left main, we can access later on. So there's what's called as a C-tab. We are able to see it the way they have made it right now. That will be, away from the left main. So if you see these diamonds, the question was, will they be distorted? Just look at it. I'm trying to compress it. Look at that. It's not getting compressed. This is
because
metal is 90 strong.
Yeah.
Okay, I'm putting pressure. Look at it. So that thought process should never exist. And goal is that when the guide is going through the diamond, you see that you're able to see this.
So much.
There's enough space.
Right.
Yeah. This
See
is a
it very
6 French.
nicely.
Yeah.
Excellent demonstration. Samin, 2 quick follow-up questions, and then there is a larger issue which Dr. Jha has raised. First of all, are you able, this is a question from Dr. L. Rice, can you put in an impeller through one of these TAVR valves?
Yeah.
Yes.
So they actually have done, but the recommendation is do not do it because there have been some damage to the valve. So you try to avoid it. But carefully, rare case, if you need to be, you do. Otherwise, do a balloon pump. So the recommendation is try to avoid putting impeller through the TAVR valve because there have been reports of distorting the valve. Impeller is a big one. So that will distort the valve, not the
leaflets,
guide
not the
leaflet,
frame,
yeah.
the leaflets.
Leaflets. Yeah.
Because of the pump.
So answer is do not practice, use a balloon pump in those cases. Next.
Second question is in the impeller for STEMI, they were all placed before the PCI?
Yes.
Yeah.
So that is a key. What happened is as soon as the patient come in, they get an impeller and then they get randomized.
Right, which is also raises the point that, these are not the cases you chase a door to balloon time, these are patients with such high mortality with or without devices. A follow-up question to that is that should every STEMI program now have an impeller?
Our answer to that is yes, absolutely yes. Now, this is the first trial positive. There is another trial going on in USA. One is the unload trial, where you bring the patient and do a half-hour impeller, then randomize the patient. Then do a PCI versus just go ahead and with the PCI. So coming back to the point, door to balloon time will be no value. Although somehow they did a great job in the danger shock, the door to balloon time remained 82 minutes. So in both the groups. So impeller did not delay. I'm surprised, but door to balloon time apparently how they calculated it's different, but there's no difference in the door to balloon time.
They have a beautiful STEMI system.
Yeah.
Because of the standard of...
Because Denmark is the STEMI, so much data.
The Dynami trial 15 years ago.
So they are so organized. The second point, in America recovers 4 is a trial for cardiogenic shock. Same concept, which is the danger shock. So I think whether it should be in every lab, I think let's wait one more. Because we have 2 negative trials of the ECMO. And 1 positive just came out with this impeller. So it's a reasonable, we wait recovers trial, maybe the data will be by mid next year or next ECT, about 1 year more before we can mandate that every lab should have an impeller. I can tell you, I have 6 labs in our periphery. 3 of them have no cardiac surgical backup. I mandated that every lab should have impeller.
Excellent. Now, Dr. Jha posed a question which leads to a bigger issue that in hindsight, should this patient have had a balloon expandable TAVR?
100%. No question.
Which raises then the question that should there be some unwritten informal recommendation that if a patient has a 50% lesion, these are better off with the balloon expandable?
So only question is, I'll tell you what happened. In this particular case, your small valve. So if you have to put a 20 or 23 as Sapien versus the Evolut. So this basically was the 23 millimeter Evolut which we did. So there, the lumen, if you put a Sapien valve, the valve area will be 1.6, 1.7. And but with a 23, with a core valve, Evolut valve, your valve area will be 1.9 to 2, about 2. So therefore, ideally, if the annulus is not an issue, all patients with a coronary artery disease should get a Sapien valve, and that is why after the low risk data were presented, earlier, I would say 5 years ago, it was 65-35 distribution of the balloon expandable and self-expanding, like kind of 60-38 actually. In last 2 years, the number is 78 versus 22. 78% getting the balloon expandable, and self-expanding is just about 20%, just because of the same region of the coronary access issue, single region. Second, people say pacemaker, yes, but majority it is driven by, now get more complicated with a smart trial. The smart trial showed that you do a hemodynamically better with a small valve, 20 to 23 millimeter valve with a 450 your valve, the millimeter square area. So what there should benefit of the self-expanding versus balloon expandable? Should you change the practice? Legal point of view, I don't know. I keep that separately. But one of the decision with the self-expanding valve, although now we have the good competitor where you can have good engagement, is the Navitor. So about 10% of our valve in Mount Sinai, we do about 45, 48 TAVR valve per month. 10% are Navitor for the same region that they have their struts. Valve struts are open, wider, and there is no issue in terms of coronary engagement.
Samin, excellent answers to some outstanding questions. I want to thank the audience for keeping us so engaged. We conclude our session here. We'll join you during the next session on May the 21st.